Hi, thank you very much for joining us for this important online training program. We are going to be going through the revised South African HIV management guidelines as published in 2019 by the Department of Health. My name is Lesego Mawela. I'm a medical doctor, and I'm going to be taking you through this training program. As part of the program, we are going to cover a number of training programs, from the high-level goals as to why these changes are important and where we are as a country in terms of managing HIV and AIDS and disease control. We will then talk about the introduction of the new drug, dolutegravir, how to use it, when to use it, what are the things that we need to pay attention to, reinitiating patients who have interrupted treatment, and how best do we monitor patients who have started treatment, what happens if someone fails treatment, and what are the options for switching. And we will close this online training program by discussing TB preventative therapy. At a high level, South Africa has made strides to try and control the disease. We have adopted the 90-90 strategy, which requires that of the more than 7 million people on ARVs, we have to identify 90% of those who are living with HIV and AIDS. We have to implement strategies for case finding and ensure that those who test positive are linked to care. 90% of patients who test positive must be put on ARVs. And we have to create programs to support patients on treatment, ensure that they are retained in care and they are virologically suppressed, which is the third 90. As of 2018, a publication by the UNAIDS showed that we are able to do a lot of testing, we are able to test and find most patients, but we have challenges with linking patients to care because of all patients who were tested positive. We could only link 68% of them to care and treatment and only suppress about 78% of patients in terms of their viral load. 78%, I generally believe that it is an over representation of the actual performance because it is a subset of patients who actually received viral loads, and we know that not all patients actually get their viral loads done due to systems challenges and so on. At population level, if you look at the total population of people living with HIV and AIDS, we are only able to initiate treatment on 61% of patients living with HIV and AIDS, and suppressing 47% of all patients living with HIV and AIDS. This is probably not acceptable, and it shows that we are far off from achieving disease control. However, we are all making strides, trying different interventions. These are quite complex issues which involve people, systems, processes, the level of community engagement, education, whether our patients are empowered for self-care, availability of medicines, adequate staffing, availability of the right equipment, and so on. We do have faith that we will achieve this target because we have to control this disease at some point. When we start ARVs, there are goals which we want to achieve. The idea is not just to issue ARVs, to all patients and without any aims. The primary aim is to ensure that every single patient who is initiated on ARVs, they do reach a state where they are virologically suppressed, right? Ideally within 6 months of starting ARVs, when patients get their first viral load as per the guidelines, we expect patients to be suppressed, and we have to institute processes to ensure that they are maintained on treatment and they are suppressed. When patients are suppressed, we are able to achieve further goals, reducing the number of patients who would experience very bad opportunistic infections, We want to minimize the development of treatment resistance. This is done through the choice of antiviral drugs that we use. This is done through supporting patients, ensuring that they are educated, ensuring that there's family involvement, and our patients have additional support when they are at home, when they struggle with taking our drugs. Clinical governance is very important because some of the reasons why patients fail treatment have to do with our everyday clinical practice. As healthcare workers, we are now introducing better drugs, very simplified. We have moved away from BD doses to once daily doses. We have moved away from multiple tablets to one tablet that can be taken once daily. We are minimizing side effects, which would encourage adherence, and hopefully most of our patients would remain suppressed, and the avoidance of resistance. We are introducing dolutegravir because it's one drug that has a high barrier to resistance, and that will also contribute to this specific goal. We know that only triple drug therapy can achieve maximum and durable viral suppression, where mortality and morbidity can be reduced. It's also quite important that before we start ARVs, we continue to screen patients, and when opportunistic infections are identified, they should be treated. Where patients are eligible for the 3 key prophylaxis therapies, we should make sure that patients are receiving those. These are cotrimoxazole prophylaxis therapy, fluconazole prophylaxis therapy, and TB preventative therapy. We want to improve the quality of life. We want to initiate ARVs and take care of our patients such that at the end our patients are better off. We do not want patients to experience side effects unnecessarily. We do not want to interfere with their day-to-day lives. We prefer patients to come in sick. We should screen them. We should treat. We should examine them. We should take proper history. We should ensure that they are on appropriate treatment. We want people to go back to their, to perform the way they were before they acquired the disease. And that is possible with the current treatments and regimens that are available in the country. And importantly, at the heart of this is to minimize side effects and toxicity. And this is at the heart of the current new changes in South Africa. Thank you very much, and I hope to see you again when we discuss the next module. Thank you.